We better get started. Good afternoon, everyone. I'm Bhatesh Jani. I'm a GP and clinical senior lecturer at School of Health and Wellbeing. And welcome to the first ever Dangerous Solutions seminar. The idea is we do a half an hour lunchtime talk on any healthcare solutions you want to talk about. And it could be at different stages. It could be just an idea at the proposal stage, or you want to share the results. So all types of presentations are welcome. So if you are interested, just drop me an email. And we're looking to have this seminar regularly Monday lunchtime, and we'll try and do this remotely so people can. We want more and more people to engage without being disruptive. So I'm delighted with our first speaker, Professor Heng Luang, Professor of Urology at School of Cancer Sciences, and he's going to talk about prostate cancer. Over to you, Heng. Thanks.
Thank you very much. Thank you so much for the invitation to speak. Is an exciting idea, and I hope I helped you set up this exciting forum and for discussions and sharing. So I pitched the title of "Doing Less to Achieve More in Managing Men with Prostate Cancer." My idea is that we want to be smarter in how we manage our patients through their journey. To begin with, I'm going to spend a couple of minutes to just share with you some of the background in terms of prostate cancer. Very common. 1 in 8 men in the Western world will develop prostate cancer.
Heng, sorry to interrupt. Do you want to maybe perhaps do it on a slideshow mode? If it's that's perfect. Thank you. Sorry.
And in terms of risk factors, we do know there are some risk factors with family history, including female members with ovarian and breast cancer, typically related to DNA repair gene defect. We also know men of African descent are at higher risk of having high incidence of prostate cancer, but also more significant disease. This slide just highlights to you, for you, majority of patients, I hope you see my pointer here, majority of patients will have early disease at the time of diagnosis. Around 20% of patients overall would have locally advanced metastatic disease at the time of diagnosis. Now, the conversation for early disease and late disease at the time of diagnosis are different. Typically, for localized disease, we can consider radical treatment with surgery or with radiotherapy. And for patients with distant metastasis or locally advanced disease, either because of recurrence or of delayed diagnosis with incurable cancer, they would typically be treated with systemic treatments, which include hormone manipulations, novel anti-androgens, chemotherapies, and also in some cases radiotherapy to the prostate itself in some situation with limited metastatic disease burden. The incidence of incurable cancer is significantly less favorable for Scotland. Here is a data from Prostate Cancer UK. The rest of the UK, typically around 20% of individuals at the time of diagnosis have incurable cancer. In Scotland, the figure is actually substantially higher, 35%. What we are talking about is that the cancer is either locally advanced, breaching the contour of the prostate into adjacent tissue, which would include the fat around the prostate, the muscles, the pelvic floor muscles, and also the seminal vesicle, which is just above the prostate, also can be affected directly. And within the pelvis, there are lymph nodes that are often involved by locally advanced disease, as well as a range of different distant metastatic sites. And all of these can render our patients to have incurable disease. The National Prostate Cancer Audit, focusing on the English data, periodically publish updates of their findings. One of the key findings in recent report is that patients from deprived area tend to present later and have worse outcome in terms of survival. And of course, deprivation can include a whole range of different factors, from obesity to other comorbidity factors. Within Scotland, I've contacted David Morrison and his colleagues in the Scottish Cancer Registry and obtained some data for a period of 5 years. And you can see that overall, in terms of stage 3 and 4 disease, we actually overall in Scotland have a 62% rate of locally advanced or metastatic disease. So this is significantly higher than what was suggested by the Prostate Cancer UK statistics. And if you look at within the breakdown of socioeconomic deprivation, there is some 10% differences between the most deprived and the least deprived group. In terms of the standardized rate, and you can clearly see that the least deprived population have a higher incidence to that of the most deprived, and that reflects the situation of less detection, less testing, and less presentations by the patients. Here is if you like, a cartoon just to outline for you the journey of the patients. Before a hospital referral, GPs either suggest in Wellbeing clinic or patients might volunteer to have PSA testing, and that can range from a single abnormal result triggering referral or a number of tests over some years before the patients are referred. Once referred, with elevated PSA, the usual management plan is to have an MRI scan done, which would highlight lesions within the prostate, suitable for targeted prostate biopsy. And from there, most of the patients now would have the diagnosis based on targeted biopsy of lesions within the MRI scan of the prostate. And of course, that upon diagnosis, the treatment and management are fairly well described. And over the past 3 decades, I've managed patients from the beginning at following referral to treatment with surgery, with brachytherapy, and also with treatment-resistant disease. And in the past 10 years or so, we have a whole range of new treatments to tackle metastatic disease. So the outlook is much better. And I think the most urgent need now is to allow us to manage patients better at the time of diagnosis, and also even before patients are referred, to improve the outcome of patients. And therefore, the focus of the rest of the talk is about early detections and preventions. And for early detections and also for patient triage, there are some commercially available tests such as Stockholm 3 and academic suggested genetic markers that are suggested to help us to determine whether patients should proceed to investigations with invasive tests, which might have potential side effects. In terms of information at a GP level, there's a paper published about 3 years ago using electronic health record at the GP level to identify men who are at risk of developing prostate cancer. So the data involved analyzed are limited in terms of the range of input factors, and also that study was looking at patients who have already had their PSA testing. So that risk score is focusing on the hospital referral period rather than before the referral has been made, and certainly and not before PSA is tested. So in the past year or so, I've been in discussion with Baltas, with Katie in your school, and also with Fanny in computing science, to really think about a way that we can develop an approach, a strategy to find patients who are at risk of dying from prostate cancer and initiate the process of investigating for prostate cancer. And in the context of minimizing overdiagnosis and also seeking out those who have the most to benefit from the investigation for prostate cancer. The idea is that we would look at public available data set and applied conventional logistic, regression logistic approach or machine learning approach to determine risk equations that can highlight individuals' risk in terms of mortality from prostate cancer once the disease has been diagnosed. And we would have respective validations opportunity for the equation from the two parallel complementary approaches. And once we've determined which equation is the most efficient, we would then proceed to testing this in a GP practice level, inviting patients to come for PSA testing through PSA testing at the working with the GP level, GP practices, and also the software company that manage the data. And of course, leading Baltas and his colleagues will lead how we engage with individuals at the GP practice to invite them for PSA testing. And working with Katie Robb, we want to refine the way we communicate with patients to invite them for PSA testing and investigation for prostate cancer. And I'll be responsible for individuals identified who have elevated PSA to manage them within the standard of care pipeline. Ultimately, we want to think about a Scotland-wide targeted screening program, looking at individuals that are at highest risk of dying from prostate cancer or have significant morbidity from the disease. And I suspect within our equations, socioeconomic deprivation will be incorporated. So within a Scotland-wide approach, I think our approach would really also help us to tackle the inequality in terms of patients from deprived area having worse outcomes. I want to quickly move to chemoprevention. And I benefit from conversation with John Cleland recently to get his advice and guidance in whether this is something that we could explore. Now, obesity and other lifestyle factors are known to be to increase individuals' risk of prostate cancer and outcome, but none of those lifestyle changes approach are known to have any impact on prostate cancer incidence nor behavior. Historically, 5-alpha reductase is a medication that is widely used for a benign enlargement of the prostate, and there are several papers suggest that the use of either finasteride or dutasteride can reduce the risk of low-risk prostate cancer. In terms of high-risk prostate cancer, the data is conflicting. The use of finasteride in patients with known low risk of prostate cancer under surveillance, active surveillance program has suggested to reduce the risk of disease progression. The significance is, the difference is not massive, and it remains whether that is clinically relevant. Recently, spironolactone and epinephrine has been suggested to have a beneficial effect in terms of the incidence of prostate cancer and mortality from prostate cancer in a retrospective cohort of patients with heart failure. And of course, a lot of our patients also have cardiovascular pathology. So within a pragmatic proof of concept clinical study, we could be considering a study engaging with patients taking mineralocorticoid receptor antagonists, asking the question of, can we prevent the development of cancer? Can we diminish the risk of disease progression, particularly in the patient in active surveillance, and of course also possibly combining treatments for significant disease with standard of care. In terms of the cardiovascular health, beneficial benefits, hypertension and renal outcome, that's something that we can also, in a holistic manner, to ask the question whether mineralocorticoid receptor antagonists can actually have a beneficial effect as a multi-system approach when we manage patients at risk of prostate cancer. So I'm going to stop here. I just reached 15 minutes, and I welcome questions and your comments and suggestions. Thank you for your attention.
Thank you, Henk. That was great, and thanks for keeping it to time. I will invite questions and comments from the audience, please. I'm trying to see if there are any hands up.
Ewan.
Hing, take me through cost and adverse outcomes. If the NHS was rich, would it use as routine PSA screening much more commonly?
Oh, it's okay. We spend a huge amount of resources in the diagnostic pathway. There's of course the government's guideline requirement for waiting time, and there's a whole team of administrators checking on the timelines. We spend a lot of time investigating patients for PSA, doing MRI scan, doing biopsies, and when those patients are negative for cancer, they still get monitored because the PSA doesn't normalize. So we have a whole, if you like, a whole pool of population getting tested. But these individuals absorbing our energy and resources are actually not at high risk. That is our problem. So our resources are not directed to the right population in the right manner. And also because we don't have a screening program. So we end up testing, the GPs and ourselves, our nurses, testing PSA far too frequently. Now, all of the screening program, people would get screened every 2 years, 3 years at most. Our patients, once they're in the system, they get tests every 6 months or even shorter. It's a huge drain of resources, and we need some smarter way to control the front door and also smarter way to manage the follow-up.
Thank you.
Thanks. John? John, have you got your hand up?
Maybe it's the sound problem.
Okay, we'll get back to John. Is Robert?
Hi there, Hing. This is Robbie Lindsay, one of the endocrinologists. Many apologies, I missed the beginning of the talk, but two things strike me. One, again, PSA, we have lots of interactions around PSA because of people who are on exogenous testosterone and testosterone monitoring. And I guess the criticism is always that it's not a terribly good test. So in many ways, you are channeling people into a test that I thought from a urology point of view, you were somewhat skeptical and uncomfortable with. And
Can you hear me now?
Sorry.
No.
Oh.
Yeah, we can hear you now, John. We'll come back to you. We just started with Robert's question, John.
And the second issue was all of those medications. I guess we're in the era of realistic medicine and trying to cut down and not have people on lots of medications. And the ones you have, you know, they're not the cleanest and they have side effect, not least sexual dysfunction, etc., and things that it would probably create a big workload in terms of people on those medications. So I wonder how realistic it is to think of many people being on finasteride, etc., if they don't have for prevention rather than for established disease. So.
Yes, absolutely. Finasteride is not really taken off, and I totally agree with you. So finasteride, dutasteride, I'm not suggesting that we consider 5-alpha reductase inhibitors as a chemoprevention strategy. I was just simply sharing the background of what has been in the past in terms of chemoprevention consideration. Of course, a lot of patients who have incurable prostate cancer end up have hormone manipulation. They are then exposed to increased risk of cardiovascular events, etc., etc. So perhaps in that scenario, we actually gain from some agents that have got anti-prostate cancer activity as well as beneficial activity in terms of cardiovascular, metabolic health. And of course, not everybody needs that. The question really is to find out that sweet spot of avoiding overdiagnosis, overtreatment, but actually finding those that are going to do badly once they have the diagnosis. And so that is where I'm coming from. In terms of PSA, although as a test off the cuff is not that good, but once we have the PSA measurement for individuals, it is a very reliable, if you like, accompanying marker for the individuals. So it's a very accurate tracker of prostate cancer behavior and burden. PSA testing on its own is not massively worse than mammogram.
Okay, good.
Thanks. I'll try and see, John, is your audio working now? Do you want to go next? John? No. Christian, and then Rob, please.
Thanks very much, Hing. That was really interesting and great to have so much information in 15 minutes. Just coming back to a much more at-risk population. So we often look at patients, of course, in medicine who have weight loss or any other kind of unspecific symptoms. And then we usually now do a CT chest up to pelvis, and that excludes malignancy. And then we're quite happy with this. We randomly do PSAs in these patients as well. Is that of any use, or what would you recommend there? I know this is not primary screening. This is a slightly different population, but I would just like to hear your opinion on PSA in people where you have a vague perception that they may have some cancer.
I don't have a big problem with that, because sometimes you do have a situation that maybe Rob might have a comment about that, a view about that. But I think sometimes it is helpful to, when you have a very unwell patients with unclear underlying pathology, I think it's perfectly reasonable to do that. And I guess when we're thinking about patient with advanced prostate cancer, is reasonable to do a PSA, but also I think it's probably useful at the same time doing a digital rectal examination as well. Yeah, just to finish the package, if you like. Rob, would you be happy with what I said there, or would you?
Yeah, so I guess in an unwell patient, making a diagnosis of advanced prostate cancer may well be to their benefit, because there can be very effective palliative treatments for advanced prostate cancer. But it still has to be applied with some common sense. I wouldn't want, because you will, if you test everybody who's sick coming through the door, you will find a lot of clinically insignificant prostate cancer, and we see these every week at our MDT. Where somebody, and of course the danger is that actually people then ignore the fact that they think they found the cause of the patient's unwellness, when in fact they simply found an irrelevant comorbidity in a lot of situations. So it's like all things in medicine, it's very tempting to replace common sense with a test, isn't it? So yeah, as long as it's used intelligently.
Yeah, I think by the time they reach MDT, they have a diagnosis of prostate cancer. The question is whether it's relevant or not. So we, from the urology end, see a lot more. But I would still say, when you see one case that is helpful in clinching the diagnosis, it's worth doing.
Yeah, PSA is used a lot as a battery of tests in general practice as well. Mila and Katie.
Sorry, Rob.
I did actually have my hand up because I had a question. Can I?
Oh, sorry, I didn't realize.
So I'm Rob Jones. I'm a genitourinary medical oncologist, so I see a lot of prostate cancer. So my question was around risk scores, I guess particularly polygenic risk scores, which there's quite a big literature in prostate cancer now. Hing, do they? Obviously, the issue, one of the big issues here is overdiagnosis. Do these tests actually enable us to identify a higher proportion of clinically significant prostate cancer, or do they simply enrich the population of patients where we might find prostate cancer?
They do not guide us to detect bad apples. And there are lots of different lists of gene sets. And I think it's just it's a growth industry. It's not ready.
Because that's what we really need, isn't it? We need a test which enriches a population of clinically significant prostate cancer.
Well, even if you have a list, it's not going to be cheap to use. So I think we need something that is free, that can help us to do the first triage.
Yeah. Can I just add? It's just increasing the pre-test probability by identifying risk factors before you do the test.
Yeah.
Yeah. Mila and then Katie, please.
Hello. I'm not prostate cancer expert, but I do work with herpes viruses, which are some of them excreted in urine, so they are in contact with all the urinary tract. So I was wondering if you have knowledge of patients with undergoing herpes infections, either herpes simplex or cytomegalovirus, or even varicella zoster, which often get leaked in the urine, and they may be infecting that tract and causing that release.
I don't have experience in that, and obviously by and large, our patient population group don't tend to are at risk of the infections that you mentioned.
Mm-hmm. Usually everybody's infected with any one or another herpes. So everybody who has had varicella, like chickenpox as a kid, have the virus latent and then reactivates later in life. The same for herpes simplex. It remains latent in you forever.
That sounds really fascinating. I'll reach out to you after this and we can have a chat. Separately, Mila.
Yeah, it's just in case antivirals against herpes may
That's
help.
very educational. Thank you.
Welcome.
Probably just room for one more last question from Katie, and I think we'll have to wrap it up.
Thank you. I can't get my other hand to work, but this one's working, so that's good. I'm Katie Robb. I'm Professor of Behavioural Science and Health, and I think my point's linked to what Rob was saying. I guess I worry about the harms of screening a lot, yeah, my concern is that that maybe you've already answered it, but do we sufficiently know the natural history of prostate cancer and their progression to ensure that we aren't just creating more patients who would never be killed by their prostate cancer and all the bad medical and psychological outcomes that brings with it?
Yeah, so in terms of case finding and screening programs, there have been 3 very large studies published, and the strategy of active surveillance for low risk to intermediate risk prostate cancer is very, very, very well established. So I think the risk of over treatment is hugely diminished in the past 15 years or so. But of course, that doesn't mean there's no risk. And certainly the anxiety issue is there. But the moment you test somebody's PSA, the man is not the same anymore. I think that we're already in that situation. And I think, and also Prostate Cancer UK and the Department of Health are funding a 40 million pounds worth of prostate cancer screening program. And within that, they are looking at very basic things with PSA, MRI, etc., etc. So screening is happening one way or the other, and as a study. But within that study, I think it's really important we take the opportunity to really shape it, to make it more likely to impact on patients who have a very poor outcome. At the moment, really, we're going to do the same thing with PSA testing, invite people to get a PSA and MRI scan. So it's not directed to people at the most highest risk of dying or suffering from the conditions.
Right. Well, I'd just like to say thank you, Heng, for
Yeah, I'm finally back.
Okay.
had to reboot the computer. It wouldn't.
We've just about reached the end, so maybe a quick quick one, if that's okay.
Well, I don't know what all the conversation was because I lost sound, but I'm a bit of a PSA skeptic. I'm really not sure about the advantages of screening the healthy population, but I'm willing to be convinced otherwise. But I haven't had my PSA done, and
I think you have you're in good company. I think most of my colleagues in this meeting are unsure about PSA testing.
Yeah.
But for full disclosure, I asked for mine check when
Yeah.
I turned 50.
Well, I'm going to turn 70 soon, and I haven't had it checked, so we'll see. Maybe I'll regret that. But from what I've seen in terms of the epidemiology of this is that people with early stage prostate cancer are much more likely to die of cardiovascular disease or something else. And therefore, it becomes quite attractive to think about mineralocorticoid antagonists, not because they will reduce the prostate risk, but I think they're just underused antihypertensive agents. And I think that we will see a bigger reduction in cardiovascular risk than we will in prostate risk. But why not reduce both with, if we can get two birds with one stone, or maybe more than two, because it could be we reduce heart failure, we reduce stroke, we reduce myocardial infarction, we reduce kidney damage, we reduce prostate cancer, maybe we'll reduce some other cancers, who knows? And wouldn't that be fantastic if you, with one agent, you could hit all those targets?
Agree.
Yeah.
Yeah.
So that's my bit.
Let's get something going.
Okay, well, thank you, Henk, and thank you everyone for a really good session. And the next session is on 20th of May, and Mila is going to talk about herpes virus. So thank you everyone, and see you soon. If you want to present, please get in touch.
Bye-bye.
Bye.